Good evening and welcome to In Conversation with Jon Strum and Dr. Jack Antel. My name is Johanna Green and I'm Director of Partnerships at the MS Society of Canada, and I am thrilled to be your host for this evening's session. Just before we begin, allow me to share a few housekeeping details. Questions for our guests can be typed in the question box at any time throughout the session. That's the box just below the video screen. We'll be answering your questions during the second half of the session. Join the online conversation and share your favorite moments from today's session by posting on Twitter using the hashtag MSConnect. Make your voice heard and respond to our daily poll on our Twitter page at MS Society Canada. This session is being recorded and will be shared at msconnect.ca in the coming days. Now, I am pleased to have the honor of introducing our guests this evening, who are both individuals that are dedicated to supporting the MS community. The first guest I'd like to introduce is Jon Strum. Jon is the host of Real Talk MS, a weekly podcast that delivers the news, views, interviews, and breakthroughs that people affected by MS need to hear. Since its debut in 2017, over 150 episodes of Real Talk MS have been downloaded more than 500,000 times by thousands of listeners in 92 countries around the world. Welcome, Jon Strum. Our second guest this evening is Dr. Jack Antel. Dr. Antel is a clinical neurologist who coordinates the multiple sclerosis research and treatment program at the Montreal Neurological Institute and was our wonderful keynote speaker on Monday. Welcome back, Dr. Antel. I will now turn things over to Jon to begin this evening's conversation.
Well, thank you, Johanna. It's great to be with you this evening. And it's a real pleasure to be virtually sitting down with you for this chat, Dr. Antel.
My pleasure.
There are any number of different topics that I thought we might get into this evening. Maybe a good place to start is to ask you about the research that's caught your eye lately. Which MS research has you most excited?
Well, I'm trying to answer that rather complex question, and I must thank you for giving me at least a little bit of advance warning. And as I was thinking about this, I think the research that is capturing my attention is the advances in being able to apply observations made at the basic science labs to the actual condition of multiple sclerosis and to people, and vice versa, how to take observations from MS itself and take it to the research lab. And to give you examples of this, as we're told that certain cells are mediating inflammation in the brain, that as we define what an MS lesion looks like, the advances in imaging, in MRI imaging, that suddenly can tell us exactly what's happening and we can follow the disease dynamically, will allow us to really understand whether we're on the right path. To be able to use samples of tissue from human brain and even from people who have MS, and to be able to apply the new cutting-edge molecular techniques. So when we say cell X is doing such and such in an experimental situation, we know whether that's really going on in the MS brain, or if we say we have to make cells behave in a certain way, that can guide the research. So I think it's the interaction from human to the lab, guiding that work and then applying it back. And almost in every area of molecular biology, brain imaging, testing for markers in the blood, the advances of applying things directly to the person with disease, I think is what catches my eye.
Well, since you mentioned some of the cutting edge advances being made today, I'm wondering, for instance, how you see artificial intelligence impacting diagnosing and or treating MS.
Well, again, what a great question. And I wish I understood that field so I could really answer that for you. But the notion that, again, if we take as an example, looking at the brain by MRI, looking at the human brain, that when we look at it, we say, yes, MS is there. Yes, there's been injury, but can we really tell what is going to happen in a dynamic way? That goes beyond what the human eye has been able to tell so far. And by using these AI type technologies, can we be better at predicting when we see an MRI to say, they can identify patterns that tell us what's going to happen, and so we know what interventions to make? Or that by taking data from large numbers of people, can the AI technology identify to say, you may be doing well now, but there's certain measures or certain genetic backgrounds or certain things in your blood test that tell us that there is going to be a problem over time. So I think as we harness this approach, it's just going to allow us to deal with these large amounts of observations that we can't do in any other way.
You know, as you were just speaking, I was thinking a little bit about how we take all of that new information, that new data that we're able to get, and an awful lot, as you know, is being written right now about precision medicine. So I'm wondering how you see precision medicine impacting the way someone with MS may receive treatment in the future.
Absolutely. And again, this is a two-way street, that as we understand what is very special or distinct about an individual, that will determine how we best intervene and what kind of therapies we can use. And it can't be that one treatment fits all. And I think that the MS community and people who are watching us tonight who are affected by MS or know people are very well aware that some therapies work better in one, some work better in others, some are less well tolerated. How do we best intervene? Are we over-treating some people and putting them at risk? And clearly there are some people where we don't have the right therapies yet. And the way of accumulating the data for precision medicine that probably everybody out there, a good number of people, are aware that you can send your DNA out to any number of places and your DNA can be sequenced and they'll tell you who your relatives were going back many generations. But everybody's DNA is different than everybody else's. How do we use this huge data set to see what's in the DNA that may be directing why the disease behaves in one way or the other in people? And that's just a huge challenge, but that's an example of the enormous need for precision medicine on genetics. And we can almost apply the same things in terms of environmental exposures of people as well, to see whether we can come up with a package that says, this is the way we proceed. So precision medicine, easy to say that that's the way to go because that's the way to go, but how to implement it, it is so complex because there's so many variables, and that's the challenge. And that's why I think your question about AI technology and precision medicine blend together so well.
Well, you know, one small bit of silver lining that we might be able to take away from the COVID-19 pandemic is the near instant availability of telemedicine. And I'm wondering what you see as the role of telemedicine in treating people with MS going forward post-pandemic.
So we are, again, learning our way. Many of us probably haven't adjusted or are stressed in this telemedicine. I do my clinic 90% of my time still by telephone, not even by video, but by telephone. And I'd sure like to see people face to face, I must say. But having said that, it tells you how we've been able to gather data, and telemedicine is just expanding. It's not just gathering data by video or by telephone to record, or there are these remarkable systems evolving where people using the apps on their mobile phones can record all sorts of data by themselves, and you're accumulating huge amounts of data. I'm aware there are apps where people can deposit their MRI scans. So all of people living far away from the major medical centers, which have a limited number of scans, for example, available. But if you're gathering information on the wider community, the more chance we have of identifying patterns that will direct us where to go. And the notion about even the apps that are coming now that can monitor how you carry out your daily activities, so we can see what determines your mobility, or if you undergo any kind of physiotherapy advice or occupational therapy input, that how do we monitor people in real time and really observe what is happening. So I think we're just at the beginning of this, as you call it, telemedicine, but the notion of monitoring people in their real setting, because people have to, that's where the action is, that's where you lead your life, and the quality of living, we've got to adjust so that people will carry it out in the real setting. Now, it is complicated. You have all sorts of issues related to confidentiality and keeping of data. We're going to have to deal with those issues, but the opportunities to gather these large data sets are expanding every day.
I'm glad you mentioned physiotherapy, because we're seeing more and more study results demonstrating that quote unquote lifestyle choices that a person with MS makes can impact their well-being and in some cases even their disease course. I think that many people living with MS sort of wait for the next great medication to help them better manage their disease. But where do you see lifestyle choices fitting into an overall treatment plan?
Well, that's very well said. And you may recall, and there may be people viewing us now that remember that the MS Society of Canada had a major symposium related to rehabilitation and dealing with issues of promoting wellness. And it was striking in terms of people presenting ways of, if we take of exercise and physical training, I won't even get into mental training, but physical training and how they could carry out activities. How do you measure that there really is being an objective response to that? And I also took away a major message from one of the speakers who said the difference between putting in exercise programs and rehab programs is that when we put in drug therapies, there's a system in place for covering the expenses, for paying for that. The resources to have ongoing rehab and training and exercise and wellness approaches, where does one get the resources and how does that put that into place? And I'm not sure we've put as much effort yet into developing the optimal ways of doing this. It was also striking to me from that symposium where we had people from who deal with individuals who unfortunately have had strokes, that their experience in the stroke rehabilitation world is that putting in a number of hours per day was much more effective than 30 minutes every few days. And so what's the optimal way of training everyone so that they can function in the optimal way, and then if they need additional resources. So it's a huge challenge. One is very attracted to the notion, and there's even evidence now from the basic biologists about how training and exercise, the effects it has on plasticity of the brain. That's actually part of the MS Connect program. Our speakers are going to deal with that. So the one certainly is supportive of this move to how do we promote well-being and activity, but the challenge, how do we put this into place? Are we using our resources correctly? There's been some disconnect, in my view, between what goes on at the medical centers that are studying MS and what's being delivered in the community. I'm not sure those two entities talk to each other as much as they should. And I think, at least from my practice, and I'm sure it's true from everyone, you feel the frustration of people affected by MS, of not being able to do what they optimally could with the appropriate guidance and resources. And we also have to understand the individuals. If you have extraordinary fatigue, one has to have a realistic program. So wellness, as you point out, and I think that's a direction we underestimate what people can benefit from.
Well, I agree. And actually, I want to circle back with you to talk a little bit more about medical center versus what happens in the community. I think that's an important conversation. But while we're on this topic, let me ask you this. Are neurologists the ones who should be talking with their MS patients about lifestyle choices?
So that's again, you're getting at very important issues. Who delivers this kind of advice and who are experts on it? I've been involved with multidisciplinary clinics for a very long time, and it's been of interest to me that in many of the clinics, if you said, who is delivering the best advice about the life choices and the activities, it's amazing to me how it's dependent on the individuals involved. In my earliest clinic, and some of people know that I started my career at the University of Chicago, our clinic, everybody identified the occupational therapist as being the head of the clinic and the one who called the shots because of her capacity to interact both with us and with the patient. So I think that there are some clinics and some centers that have done better of providing this, but it's also as a great difficulty. It's to provide ongoing care, monitoring, responding when you're at a distance from individuals. So how to get this translated into the community, and it almost takes us back to the earlier discussions we've had, if we can take advantage of technology. So maybe by the various apps that the communications can be more frequent, more constant, the guidance can be delivered into the home setting. I think we're going to have to do that because it's not, obviously MS is not going to be as simple as giving somebody a pill or an injection and making the disease go away.
There's been mounting evidence about the benefit of exercise, as you pointed out, even down to the cell biologists who are finding upside to exercise for people living with MS. So are we at a point where exercise should be prescribed to people living with MS?
So I think I have to be a little bit cautious in how we're answering that. I think we should make sure that we don't say, do exercise, follow a diet, and don't partake in other therapies, particularly the pharmacologic therapies that have gone forward. I think nobody would question now the major advances in managing MS that have come from if you will, the frontline pharmacologic therapies. Prescribing exercise is not absolutely straightforward. What do you tell people to do? It depends on what their ability and disabilities are. How do you design a program that people can really follow? And I think this requires a lot of probably intervention and monitoring. That I would venture to say that most people, if they've been seen at a major medical center, have probably seen a therapist maybe once a year or twice a year, but that is probably not sufficient to optimize what they can get out of exercise. The other problem, of course, is it's easy to say go exercise, and I suspect if I said to everybody listening to this evening, well, go out and exercise an hour a day, some people would say, isn't that wonderful? And others would say, this is torture. So how do you design a program that people can actually do and partake? And I think that that's a real challenge. And in MS, it's a particular challenge of how you get this into place because of the fatigue factor that many people with MS face.
Which is a bit of an ironic double-edged sword in that there has been research that also shows exercise can actually work to help people with that fatigue. So how do you get started when there's not enough gas in the tank to turn the engine over, and yet you're better off if you do? And by the way, I completely agree with you. I didn't mean to suggest prescribing exercise instead of a disease-modifying therapy. First and foremost, everybody needs to be on a disease-modifying therapy. But as you mentioned, adherence to exercise programs, frankly, the same challenge exists for adhering to a disease-modifying therapy. We can point to the science that shows the patient how beneficial and how important disease-modifying therapies are. Yet we also know not everybody starts, and we also know earlier treatment is better treatment, better outcomes. And yet not everyone starts early, and not everybody stays with it.
Right, but I think with the therapies we currently have, we've certainly advanced. I mean, it's quite remarkable when many of us, when we started with the interferons, how many people actually stayed with it. But the dropout rate with ongoing daily injections and side effects, even then it was impressive who stayed with it. It is easier to swallow a pill or take an intermittent injection once a month or every 6 months. I mean, but think about the number of people who've gone on, and it's interesting, the number of studies that have been done on diets in MS, most of them have run into trouble with non-compliance of the diet. So it is so exercise, diet, lifestyle changes are more complex to carry out than taking a straightforward medication.
Let's talk about those medications for just a moment. With more than 20 approved disease-modifying therapies available, we see some that are considered very safe, but not very powerful, and others that are considered very powerful, but they also carry more risk. And this leads to a decision about which disease-modifying therapy does someone with MS get started with. There are some clinicians that tend to start with lower risk, less powerful treatments, and then step up to more powerful therapies as or if needed. Others would recommend starting with a very powerful disease-modifying therapy and really meeting that patient's MS with very powerful medication from the very beginning. What are your thoughts when it comes to this debate?
So nothing is simple. And that's because MS is not a simple disease. If the whole MS disease was the occurrence of inflammatory lesions in the brain, then it would be a simple process, because we're fortunate in the field that we have the powerful technology of MRI imaging, where we can see these lesions forming, and those are the substrate that correlates with relapses. And if that's all we had to do was to stop the relapses, then you could work out a paradigm where you would simply take whatever is the safest medicine. Could you control the development of the inflammatory lesions? The dilemma is, I think, that this issue of why do you also have this progressive phase of MS, and if you are allowing activity, is that going to eventually drive the disease progression? And is there, with our current medicines, with the more powerful ones, are we really going to reduce the risk of development of progressive MS? The question you're asking is also a relatively recent one, because it's only in the last relatively few years that we've had powerful enough medicines. When the first drugs came, like interferons, we put people on and said, okay, that's the best we can do. We've now moved to the era of, can we really control the disease? So that, and then as you mentioned as well, we have the safety issues. We have an age group, especially women who have childbearing age, and even men, issues of fertility. So you have to really take all of these into account. But I think the issue of putting people on one of the lesser agents and allow disease activity to continue, I think the data has emerged that we really want to control the disease activity as best we can. So that's where I think the move is towards the more powerful agents. Once there's evidence that the disease activity, that you can now start to identify people who are likely to have disease activity. So we can make judgments, I think, earlier on who's likely to have disease activity, and that makes it more attractive to go to one of the more powerful drugs early on. But I think, again, we're going to keep coming back to almost every one of your questions by saying it's got to be personalized, and you have to take all of the factors into account. There are clearly people that if you told them the ideal medicine is an injection, they're going to say, I don't want the ideal medicine. So I think we're balancing risk and benefit, but we have some pretty good guiding principles now. And I think one of the advances also from the careful clinical studies and from the MRI studies is that we have moved from, okay, we'll put you on a drug and wait to see what happens, to having some pretty good predictive parameters that say, this is a case where it's not going to be controlled so easily, and a move to a more aggressive therapy. The reverse is also true. Are there people that we could predict are likely to have a rather benign course, and so that we don't overtreat either?
I always encourage my listeners to share their thoughts with me, and they aren't the least bit shy about doing so. And when I look at the email and tweets and texts that I receive, some hot topics begin to emerge. So I'd like to talk about some of those. And one topic that a number of people living with MS tend to talk about is stem cell therapy. That's a broad term that can actually mean a variety of different therapies, which really only contributes to the confusion among people affected by MS even more. Now, a couple of weeks ago, the US National MS Society published their recommendation for autologous hematopoietic stem cell transplantation, or AHSCT, as a treatment for MS patients who are under the age of 50, living with relapsing remitting MS, experiencing mild disability, for whom disease-modifying therapies haven't worked. Looking forward, what do you see as the potential for stem cell therapy?
Right. So I think that in some ways the choice of terms that the program that you refer to as stem cell therapy is a bit of a misnomer. What that is referring to is using such high dose immunosuppressive therapy that you're wiping out the bone marrow, and the person can't survive unless the bone marrow is reconstituted. So the stem cell therapy is to restore the bone marrow. The actual therapy that is being effective for the disease is the high dose chemotherapy that's given as part of this. Now, I think it is a remarkable finding. In Canada, we point to our colleagues in Ottawa, Mark Friedman, Harry Atkins, who pioneered this, and that the remarkable observation that none of the people, even 10 years later, have had recurrent inflammatory disease, so that this reconstitution of the immune, wiping out the immune system and reconstituting it is provided almost as if we wiped out the whole immune system. So we wiped out your good immune cells, we removed your bad immune cells, and then when we gave the transplant, only the good guys came back. I mean, that's quite a remarkable observation. Now, we have to keep in mind, and we've learned, but there is a risk from using that approach. And there's also just the logistics that this is not a therapy that can be given to millions of people. And we also, that data is a little bit dated in the sense of, as these guidelines were developed, of course, we've gotten and are still getting more and more therapies that seem to control the disease without the need to go to this more drastic approach. So I wish we had a better name for this, because as I said, this is not stem cell therapy. This is stem cells are the rescue of the immune system. So that is, I think, one part. And the other, which we unfortunately, but we do have to call to attention, that using this therapy in people with progressive MS has failed. So that would have been a remarkable finding if it turned out that if we went to the limits of treating the immune system, we could deal with all phases of MS. That would have been remarkable. So this has been an unfortunate lesson, but driving us to look for different mechanisms that drive the progressive phase of disease, because the high dose immune suppression bone marrow rescue therapy is ineffective in the progressive phase of disease. And if you look carefully at the cohorts of people who've received this therapy, where their relapses have stopped, there are examples of people who've then still developed progressive MS. Now, you could argue that maybe they already had progressive MS when they got this therapy, but again, keep it in mind that unfortunately, this is not the therapy for progressive MS.
Right. You know, I'm here in California, so forgive me if I'm not fully aware of conditions on the ground in Canada, but do you have the proliferation of what I'll politely call stem cell clinics that, by the way, have nothing to do with any of the treatment we've just been talking about, but rather seem to exist to extract as much money as they can from people who are desperately seeking some sort of resolution to their disease? Is that a problem in Canada like it is here in the US and elsewhere?
The problem, although I may not know everything that's being done on the side, so to speak. In my own practice over the years, I've had people travel all over the place to get stem cell injections. Often I'm not sure I know what was being injected. It brings to mind a lady that I knew many years ago who went off-site somewhere and eventually presented with a fever of 42 degrees centigrade, had an overwhelming systemic infection, so that, and again, it's almost impossible to know what's being given at the various therapies. I think it's more of a problem outside of our country. But again, it's really, as you say, it's unfortunate of all the things that are being injected into people. And I am certainly sympathetic to people saying, look, I'm not doing well. This may be my chance to have a therapy, and maybe I'll get out ahead of things and have it done. Now, there are serious studies looking at other forms of therapy, of stem cell therapy, because many of the stem cells, and even the ones that you're referring to where we're not sure what the aim is, but generally speaking, the issue is if you have a damaged organ, is there a stem cell? And what a stem cell is a cell that has the potential to turn itself into any other cell in the body, so to speak. And is there any possibility that giving a stem cell, that a stem cell would recognize there's damage in the brain? Would it get to the brain and would it repair? And then you face the issue, if you give it in the blood, how does it know to go to the brain? Do you have to inject it directly into the brain? And of course, if you're starting to have to, there is actually a major, well thought out clinical trial by my colleagues in Milan, Italy, where they're giving stem cells that have already been programmed to have the properties of brain cells, and they've been injecting it into the spinal fluid. And those are still early type studies. Even in the animal models, I think the disappointment may be too big a word, but the stem cells don't seem to be as smart as we thought they were. That they don't just run and find the broken place and fix it. And if we have to think in terms of putting in stem cells directly into the brain by injections, that obviously is going to be more complicated. if I can extend that discussion a little bit, that there are actually cells living in the brain in everybody, which are cells that aren't totally stem cells. In other words, they can't become anything, but they are still rather immature, undeveloped cells, but they have the early properties of cells of the nervous system. And it is clear that some of those cells can be provoked to actually take place in tissue repair. And I think this is a promising area. If we can find ways of provoking the stem of these, what we call progenitor cells that are already in your brain, if we could find ways to mobilize them, then I think there is a real chance of contributing to repair.
Well, I said I wanted to circle back at some point to a comment you made referencing the medicine being practiced in the community versus what may be happening at an MS center, for instance. You know, we often hear that MS is a complex disease that really requires comprehensive care from a care team representing, just a wide range of disciplines. But so many people living with MS don't necessarily live close to a place like that, and they may not even live close to a major metropolitan area. So how does that geography affect the overall quality of care these patients might receive, and what do we do about it?
So I have to be a little bit cautious how I answer this, because our medical system is not your medical system. And maybe I'll leave it at that for the moment. In the community that I practice in, which is the province of Quebec, we are extremely proud that we have a network of neurologists interested in MS that probably cover virtually much of our region, and working together and sharing information that whether we cover a rather wide segment of our population, and that's probably true in many of the regions in Canada, but others can talk about their own regional issues, so that clearly we've overcome one of the issues, and that is everybody has access to medical care and the access to the medications that we're talking about. Having said that, there clearly are communities where people are not going to be able to travel large distances. We still have problems in our country with access to medical care, which seems to be an unusual situation given how many people would like to be in the medical field. I think going back to our initial discussion about the new emerging technologies and communication between the medical community and people affected with this disease, and that sharing of information, so there is contact and communication between people on the ground in the smaller communities with what's going on in the other areas. In some areas away from the big metropolitan areas, there may actually be better access to things like physiotherapy, rehabilitation services, accessing the medical center. There are medical centers in our community, of which I happen to be one, where some people said the main thing that we're lacking is a parking lot. So I think that I think you've identified the problem, and I think that can we develop the communication technologies that we can help at least deal somewhat with the challenges of people who are away from the main centers. But even access to the main centers is not simple. Dealing with and I think that's true in other countries as well as the medical system is bizarre and complex, and we have to do better at making it easy to navigate through.
Well, I think Johanna has some questions that she's lining up for us. So Johanna, why don't I throw it back to you to handle some questions?
for just a fascinating conversation. As you said, we now this shift to questions from our audience for either Jon or Dr. Antel, and a reminder that you can type those questions in the question box just below the video box, so that's separate from the chat box. Okay, it looks like I've got one on my screen. Are we any closer to understanding why MS occurs? The million-dollar question, right?
So we don't know precisely what triggers it. But we know a fair amount about. We know some things that can help answer that question. That we know that, again, as I mentioned in my initial talk the other night, that we know that your genetic makeup predisposes to the development of the disease, that it is likely that exposures to a variety of environmental factors trigger your immune system. I think one of the reasons that we're having difficulty sorting this out is because both the environment and the genetics are complicated. So if some of you who heard me speak the other night, I mentioned animal models of MS, where if you inject a mouse with material from the brain, the mouse will get an inflammatory disease that looks somewhat like multiple sclerosis. So the immune system coming into the brain. Well, what I didn't tell you is if those experiments are done in very specific strains of mice who've been raised under very strict laboratory conditions. And if you take a specific strain of mouse and raised under a specific condition, and you inject 100 mice, almost all of them will get sick. If you go out and catch 100 mice out in the field and inject them in exactly the same way, you'll be lucky if 1 out of the 100 mice gets sick. And that's maybe why the issue of what triggers MS and is so complex, because we're dealing with an outbred population living in a mixed environment. So the same stimulus that could trigger something in one person will not trigger it in another. And that all these variations determine whether at any one moment you're susceptible or not. So the best thinking still at the moment is that there is, at a specific moment in time, your immune system was triggered in a unfortunate way, so that some of the components that should be fighting off something in the environment are redirected to recognizing something in the brain. Now, how do you prove that? That is a bit more difficult, but I would suggest to you that the experience with controlling the disease by blocking the immune system in one way or another is pretty strong evidence that that's the mechanism. So it is a misdirected immune response, but it's not going to be exactly the same in every single person, because everybody has these variations in terms of genetic and environment.
Thanks so much, Dr. Antel. As always seems to be the case in MS, it's complicated, right? Jon, a question has come up for you, given that you have done hundreds upon hundreds of interviews with experts in MS. Someone's asking, what's caught your eye in MS research, given how closely you follow it?
Wow. Okay. Let me see. What has caught I'll tell you what. Themes catch my eye sometimes more than specific research. One of the themes that I've noticed over the last 12 to 18 months is people are using the word cure more often than I've ever heard it before. Now, we have to be careful how we define that, because cure can mean different things to different people. For instance, if you technically had MS, but you were completely free of symptoms, you'd kind of be cured. You'd be cured enough, I think, for an awful lot of folks. Or if you were able to restore lost function, that would certainly be considered by some to be a cure. Or if we were able to stop progression, again, that would certainly be considered a leap forward by an awful lot of people who worry about progression every single day. So I think that the idea of cures, multiple, not singular, that's kind of a new theme that I've noticed more and more often, and that certainly caught my eye because that's obviously the end game for all of us. I always I always tell people who ask that I look forward to my last podcast because that'll be the one where I can say, and now we don't have to worry about living with multiple sclerosis.
If I
Fantastic.
can I make
Of
one
course,
comment? When you say we always say it's complex, I think we better keep that in mind because it's not straightforward, and we have to understand the complexity because that's how I think we'll finally unravel the differences from one person to another and why someone gets the disease and someone doesn't. The complexity is, I think, what marks multiple sclerosis differently than many of the animal experimental models where we're always reading about, oh, we stopped the disease, we regenerated the brain. The reason that it doesn't always, so far we haven't successfully completely translated it because we're dealing with a more complex situation.
Question that's come in from Lori in Yellowknife, Northwest Territories. Dr. Antel, I think probably you can take a stab at this one. How do you ensure that the community doctor and neurologist are on the same page for treating the patient, especially when you're a community with several locum doctors?
So again, what an important question and challenge for us to meet that, because many of us don't deal with that in our day-to-day activity, and I think it's a very important issue. The having events and teaching events, I think, are important. Again, in our community, we've tried to set up a network of interactions amongst the doctors in a wide area so that all can partake, and that we also, as I say, I hope that with the increasing communication, it will be easier to do that. It is, I can imagine how difficult it is for a doctor in a community, often practicing by themselves or in a small group, that of all the things they see, although we think of MS as becoming a relatively common disease, it is not a common disease in a general practice, and that I hope many of these doctors will reach out for help. And whether, as we talked about telecommunications, whether we have the way of interacting in a way that we haven't been able before. I think the day of saying, oh, well, if you have a patient in the Northwest Territories or in Yellowknife, wherever you are, just on an airplane and comes 1,500 miles away, I think we can do better than that.
Absolutely. There's many steps to yet be taken to improve all of that. We have another question from Lenora in Vancouver. How much do you feel stress factors into the development of MS?
Is that for me or for John?
I'm going to let you take that one, doctor.
So it is an attractive notion, and yet the studies that have been done have been rather unconvincing. And that there were studies done in the early days of MRIs where they were trying to see whether relapses as measured by new MRI lesions correlated with times of stress or not. And they were really not very convincing. Now, really, it is true that stress will have an effect on the immune system, but in terms of new inflammatory activity in the brain, that the data has not been very convincing that stress has been what is triggered. Now, stress obviously can have an effect on how we function overall. So people with neurologic deficits are likely to function less well under stress conditions. And that one can bring out in various physiologic studies. But if the question is stress what triggers MS? using this very narrow definition that I've given you, the new activity of the disease, then I think the data is really not very convincing.
Interesting. Dr. Antel, this next question is also for you. It's from Valerie in Chilliwack, asking how you feel about Eastern medicine meeting Western medicine and working together with disease progression.
So I think the answer is, and again, if I refer back to my talk of the other night, that if you look when people count the claims for therapeutic success in the 1930s of progressive MS, the claims were better than what we claim today. That the one doesn't really necessarily criticize the Eastern medicine approach, whichever you want to lay out. You tell me what the approach is. My answer is let's subject it to the modern way of measuring effectiveness. And in MS, we are fortunate that the different components of MS, so particularly the relapsing MS, which we've been talking about a lot this evening, with MRI measures, that we can measure objectively. You tell me what the measure you want to put into effect is, and one can try and come up to tell you how effective it is or not. The progressive MS until now has been more difficult because we don't have a rapid readout, but we are approaching that very, very quickly with biologic markers, with new MRI imaging, to see whether we've changed the rate of progression of disease. If you say that you have a therapy that makes people function better, we can measure that as well. So I think that we should be open to whatever suggestions that come forward, and we shouldn't dismiss out of hand unless there's a clear toxicity. But for all the people who are making claims about different types of therapy, what they owe us, and they owe the people living with MS, is to subject it to objective measurements so we can say yes or no as to whether this is effective or not. And so when there's claims done in any other way, and marketing of technology, of approaches or medicines or whatever, diets, whatever approach you want to say, when it's not been subjected to appropriate measures, I think that we can be very critical of people who make those kinds of claims.
Thanks, Dr. Antel. So, Jon, we have a question for you. Given you do so much work on the international MS front, can you tell us your thoughts on how global collaboration has impacted people affected by MS?
Well, I can certainly speak to that, and I think I can speak to it more on the progressive MS side. I am a member of the International Progressive MS Alliance Scientific Steering Committee. And one of the things we have done over the last few years is we have funded global collaborative research networks where you have a single project that may have a principal investigator in one country, part of their team in 2 or 3 or 4 different countries, all working together. And that's proven to be a very, very efficient way of moving progress forward at a rapid clip. And I should also point out that one of the 3 multi-year projects we're involved in at the Alliance that we're funding, the principal investigator happens to be in Canada. And they're looking at using artificial intelligence as a way of searching for through MRI scans to see if there might be a marker that will be predictive of MS progression. And it's the same sort of technology that NASA uses to identify planets in distant outer space that even the telescopes can't pick up. And this would be bringing that inward to be able to look for some sort of visual clue or cue that this person may be dealing with progressive MS in the future. And they still have much work to do, but we've seen great success using international collaborative teams to look for answers. And I think that from the people I've spoken with, and I get to talk to an awful lot of folks who are affected by MS, nobody really cares where the solutions come from, whether it happens to be locally or distantly discovered. I think we're all looking for those solutions from wherever.
Let me put a plug in for this. I've been fortunate to be part of the other two programs, and one is coordinated out of Milan by my good friend Gian Vito Martino. And just to give you an example, in my own laboratory, we have a research question at the moment that relates to human cells repairing the brain. And we turned to a close friend and colleague at Münster, University of Münster in Germany, Tanya Coleman, who is being an advisor to our program, and we work very closely with Tanya. Our collaborative effort involves the group at the Salpêtrière in Paris, a group in Germany, the group in Milan, and with modern communication, that it's extremely easy to interact with them. And I think that, as John was saying, that most of us, we'd like to be part of the group that finds the cure, but the cure will be the main thing in the breakthroughs, and we need to share the technologies. A challenge, of course, is how do you sustain this? And that, there's so many, I guess it's fortunate that there are many extremely good people. The Progressive MS Alliance will go through its next round of funding. How do you support all of the people who potentially have very good ideas? So it's an expensive enterprise, but we need to take advantage of all the tools that we can.
Perhaps a really hopeful note and promising note to end today's discussion on. So encouraging to see that the globe is truly come together in a unified fashion to hopefully fast track some of the questions that we face in MS and get to those answers as quickly as possible. As we draw to a close, I'd like to take this opportunity once again to extend sincere gratitude to Dr. Antel and to John for a fascinating conversation tonight and for taking the time to join us tonight and be such a meaningful part of our MS Connect conference. We really appreciate it. One final note. Thanks so much. One final note that I want to remind our guests about is that we have a team of MS navigators through the MS Society who are available to connect toll-free at 1-844-859-6789 or by email at msnavigators@mssociety.ca. So if you have a specific question that you might have asked today that you didn't have a chance to get an answer to, we encourage you to reach out to one of our MS navigators. Also, before we close, I'd like to take this opportunity to once again thank our sponsors for providing the support that truly makes this conference possible. I'd also like to take a moment to recognize one of our MS Connect contributing sponsors, Pendo Farm, whose Ally Support Program is available to help people on their MS treatment journey. Don't forget to visit our vendor fair at msconnect.ca/vendor fair, where you can learn more about all of our vendors. And be sure to check out msconnect.ca/research posters to learn more about the fascinating work of up and coming MS researchers. Last but not least, I'd like to thank each and every one of you for investing your time in learning more about MS and MS research. A reminder again that all of our research sessions are being recorded and will be available for viewing at a later date at msconnect.ca. In fact, if you go to the schedule section at msconnect.ca, you can already access some of the sessions from earlier this week that were recorded. We look forward to seeing you tomorrow at our session with Dr. Catherine Larochelle on menu, metabolism, and microbiome in MS, news and research advances. Have a wonderful evening.